Welcome to SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode number 8. My name is Scott Okuno. I'm a medical oncologist at Mayo Clinic and Chief Medical Officer for SARC. All episodes are posted on our website, Spotify, YouTube channel, or wherever podcasts are available. Please place comments as we look at these and we want to serve your needs. Today, our guest is Dr. Mark Dickson, Associate Attending Physician at Memorial Sloan Kettering Cancer Center. He is a sarcoma medical oncologist. His area of research is liposarcoma. As we celebrate Sarcoma Month in July, we want to learn more about liposarcoma and the options that are available. Dr. Mark Dickson, welcome to SARC Talk.
Thanks, Dr. Kuhn. I'm very happy to be here.
Mark, you and I have known each other for some period of time, but maybe you can describe how you got interested in sarcoma and how you got to Memorial Sloan Kettering.
Yes, sure. It's a good question. I think it happened organically, and I can't tell you that I was a 12-year-old boy who wanted to be a liposarcoma oncologist. It didn't quite work out that way, but I did go to medical school in New York City at Columbia and was very interested in oncology even then. Certainly treating cancer seemed to be one of the biggest challenges in medicine that we would face over the timeline of my potential career. And so I wanted to go to internal medicine and medical oncology training, and really the best option anywhere nearby was Memorial Sloan Kettering, which has a great reputation. And I started fellowship here in 2006. And I was really open to many different kinds of cancer medicine at that point and relatively undifferentiated. But like many things in your career, it happens to matter a lot which mentors you have and which opportunities you have as time goes by. And I was lucky enough to have mentors who were involved in clinical research in rare diseases. So initially I was interested in both melanoma and sarcoma, and also phase 1 studies where new drugs are being tested in people with all sorts of tumors for the first time. And that was a big part of my research interest as a fellow. And then when it was time to get a first faculty job, the opportunity due to some departures at our institution was to take on a role seeing patients with both melanoma and sarcoma. And a couple of years after that, transitioned full-time into sarcoma care, just given the sort of volume of patient care and clinical research that I was doing. So that's sort of how it happened, and the rest is history.
It's interesting. At age 12, I didn't know if I even know how to say the word liposarcoma. But I think a lot of what we're hearing from a lot of sarcoma oncologists, opportunities come up, their plans change, and they fell in love with, dealing with men and women and patients with sarcomas. And I think that's a kind of very unique thing in our field. When none of us grew up wanting to be sarcoma oncologists, yet alone, liposarcoma oncologists. So thank you for sharing about that. And, we're blessed to have you at Memorial taking over a lot of that practice in liposarcoma and focusing on liposarcoma. Sarcomas are a big field. And, we're not going to tackle all of sarcoma today, but there is a subset of patients that have liposarcoma. And maybe you can describe a little bit how you discuss liposarcoma, the types of fatty sarcomas with your patients, so we get a flavor of how you parse out liposarcoma in your practice.
Sure thing. Yeah. I mean, sarcoma is both a big field, but also a very small one. And what I mean by that is that they're relatively rare diseases, right? There's only about 12,000 cases of soft tissue sarcoma a year in a large developed country like the United States. So when you compare that to the total cancer burden, it's 1% or even a little bit less than that. Obviously, the cancers of the organs, which are usually labeled carcinomas, like breast cancer, colon, prostate, lung, those common ones are much more common than sarcomas. So it's a relatively small field in that sense. But then when you actually dig into what those 12,000 cases are of sarcoma, there's over 100 different subtypes or flavors of sarcoma, and the classification is enormously complex, even for people who are steeped in this field and work in it every single day. And the latest World Health Organization classification system for sarcomas has over 100 different subtypes. So it's very complicated. The nomenclature is complicated, and it's almost true that every month a new sarcoma subtype is identified and named and published on. That said, there are some sarcomas that are more common than others, and liposarcoma is still one of the more common soft tissue sarcomas to occur in adults. So when I'm talking about to patients, I try to explain this high-level view of what the disease is. It's a cancer of the soft tissue or the connective tissue. So if you have a cancer that develops from bone, muscle, fat, cartilage, it's a sarcoma. And in particular, if you have a cancer that develops from a fat cell or an adipocyte, it's a liposarcoma. It's very rational for patients to ask, why did this happen to me? I think everyone would wonder that. And the answer is a bit difficult to formulate. I think in most cases, we think of liposarcomas as chance or sporadic events. They're just bad luck cancers that people get associated with the normal aging process and not associated with any obvious risk factor like, lung cancer with smoking, et cetera. And although some cancers are associated with cancer predisposition genes where many people in the family may get cancer, great example of that is BRCA, where there's strong family history of breast cancer and ovary cancer. For most liposarcomas, that's not the case. So these tend to be just sporadic kind of bad luck cancers that are found when people come to medical attention with abdominal mass or something like that.
So, Mark, it is a daunting task. Even saying the word nomenclature is hard for me to say as well. But as we think about this, I know that we rely heavily on pathology. We rely heavily on our advanced imaging part. Are there certain things in the pathology report and the imaging report that clues you off that this might be a liposarcoma or one of the liposarcomas that we typically see?
Definitely. I mean, one of the things that's helpful is to review the imaging, which is, for an abdominal liposarcoma, it's often a CAT scan of the abdomen and pelvis, particularly with a radiologist who has experience in these diseases, because there are a lot of things that can cause masses in the abdomen in human beings, and the figuring out what it is just from how it looks in the CAT scan requires quite a bit of expertise. And I think I'm going to keep coming back to that because of the rarity of the diagnosis. It really is helpful to have experts who see the diagnoses a lot and are familiar with it. And that is at every level, in radiology, pathology, medical oncology, surgery, radiation oncology, et cetera. So I think there's certain features of a fatty mass in the abdomen, which look like a liposarcoma, particularly if you see these a lot. And then, of course, the gold standard is to do a biopsy where a radiologist usually uses a core needle to take out a piece of tissue, and it can be looked under the microscope. And there again, having an experienced pathologist is very useful because they can do the correct ancillary tests to figure out what kind of sarcoma it is. And that can include just the appearance under the microscope, but also immunohistochemistry staining and various molecular studies as well to look at the DNA of the tumor or whether there's chromosomal translocations and so on. And all of that is taken together to come up with the correct diagnosis. And everything flows from that. You have to start with the diagnosis before you can even talk about the prognosis or the treatment plan.
To follow up on that, you brought up the word, you need to have a team that has experience seeing this, evaluating it, and working that up. A lot of our patients don't have the ability to go to referral centers or go to access. Are there opportunities at your institution, Memorial Sloan Kettering, to have slides sent to you, images sent to you, and you do virtual visits or consults that way?
Yes, definitely. And that's a big part of our work. So I think a lot of times if a patient has a biopsy at a community hospital that's not a sarcoma center and the diagnosis is unclear, the pathologist will send the tissue for a second opinion at a major sarcoma center like ours. And we also see patients from all over the country and all over the world who come for advice and guidance and second opinions on their treatment plan. In the past, that used to involve traveling to New York in most cases, but since the pandemic has revolutionized how we practice medicine, and we now do telemedicine and remote care very routinely, we're often able to see patients for second opinions remotely through video visit, with some limits and constraints having to do with medical licensure requirements. But that is certainly a very a useful thing, I think, in both directions. We learn more about the diseases by seeing patients from all over the world, and also we can provide a useful service to help them get good care.
Absolutely. And that brings the expertise closer to people who might not have that ability, as you said, within limitations. You started to use some terminology, and I know you backed off a little bit on the word well-differentiated liposarcoma, atypical lipomatous tumor, myxoid liposarcoma, high-grade pleomorphic liposarcoma, D-differentiated liposarcoma. This is the splitters that are going to be needed as we start to parse out liposarcoma. And I think each of these words means something to somebody, but they also impact treatment options. And maybe you can just, at a high level, describe how you use some of these to help make decisions on the four broad categories of low-grade myxoid liposarcoma, high-grade, and D-diff liposarcoma.
Absolutely. It does, the naming does get a bit complicated, but it's actually quite critical and worth spending a bit of time to parse out. Cancers exist with different levels of aggressiveness or malignant behavior. Some are more low growing, which means they can be slow growing and have a lower risk of spreading elsewhere in the body or metastasizing. And they can be more high grade. And so that spectrum is a good way to think of liposarcoma. So on the low grade end, you can have an atypical lipomatous tumor, which is a bit like a lipoma, a subcutaneous fatty mass underneath the skin, which many people have. They're benign and quite common, but it's a bit bigger and a bit more aggressive than a lipoma, and that's usually found in the extremities, the arms or legs. And when that same tumor is found in the abdomen, in this big space that holds all the abdominal organs called the retroperitoneum, it's called a well-differentiated liposarcoma. I may call it well-diff lipo for short in the coming minutes. And that's also a low-grade tumor, which tends to be slow-growing. And then you can have a more aggressive high-grade component, which is called D-differentiated liposarcoma, or D-diff lipo for short. So that's one big group, that category there of liposarcomas. That's one of the more common liposarcomas that you get. And then there's two other groups that we need to talk about. The second one is the myxoid liposarcomas, and these have a different biology. They have a unique chromosomal translocation that drives their growth, and they have a different presentation. They look different on the scans, and they have a different pattern of spread in the body. And the myxoid liposarcoma is the more low-grade variant, and then you have a more high-grade variant, which is called round cell. So you may hear the term myxoid round cell liposarcoma, or MRC sometimes. That's the second big category of liposarcomas that we see in adults. And then the third, which is a small group, is called pleomorphic liposarcoma. And these are their own biologic entity that tend to behave rather more aggressively with a higher chance of spread and metastasis, and they're treated somewhat differently. So at a high level, those are the three big families of liposarcoma, and we classify them that way and then treat each differently depending on the diagnosis.
That's an excellent summary, Mark, because I think when someone comes to our office and says, I have liposarcoma, we need to know which of the three big buckets they are, and a breakdown of the well-differentiated liposarcoma versus the D-diff, because treatments are different. And as you said, the other two groupings have a total different biology and treatment and prognosis as well. So I think people come to referral centers with an expectation that you're going to do the deep dive, understanding which of the buckets that you're looking at, but ultimately they want treatment options. And as you start to look at these three buckets, or maybe four buckets, what are your treatment modalities that you typically would look at? Let's say the low-grade ones first, and then we can go into the more aggressive high-grade, and we'll skip the myxoid liposarcoma just for time's sake, but just mostly how you deal with the low-grade versus the more common, the other component, the D-diff liposarcoma.
Yeah, for sure. So low-grade or well-differentiated liposarcoma is primarily treated by surgeons. So a pretty typical story will be that a person in their middle age, 40s, 50s, 60s, 70s, arrives with increasing abdominal girth. Maybe they thought they were just gaining weight, but they finally come to medical attention and get an ultrasound or a CAT scan. They see a tumor there. That looks like a fatty mass and is biopsied and found to be a well-differentiated liposarcoma. So the treatment of that is optimally, it is surgery. So we work in concert with our surgical colleagues to have these tumors completely removed. It's certainly wise to see a surgeon who's a sarcoma expert and has experience in doing these type of operations, because the surgeries can be quite complex, particularly for the bigger liposarcomas, because sometimes adjacent organs need to be removed as well as the tumor. Those organs could be part of the intestines or part of the spleen or the pancreas, etc. And those can be pretty big operations. But for well-diff lipo in the abdomen, that's usually the best course. What other options are there? Well, in some cases, you think about chemotherapy or radiation, just in general when treating cancers. But for well-diff lipo, those are probably not standard. There's some controversy in the field on this, but I think most people would agree that chemotherapy doesn't have any useful role in well-diff lipo. And radiation, it remains an open question. There's some clinical trial data that suggest it may help some patients with well-diff lipo, but it's still not quite settled. So surgery alone, if at all possible, for well-diff lipo is usually the way to go. And then you have the more aggressive high-grade dedifferentiated liposarcoma. And that, again, is a situation where there's some controversy in the field. If the tumor is in the extremity, like in the thigh, for example, surgery is still the standard, but many people would consider radiation therapy if the tumor is large to try to reduce the risk of the cancer growing back in the same place where it started, which is called a local recurrence. And there's also an ongoing clinical trial looking at the role of immunotherapy with a drug called pembrolizumab to see if that improves the outcome in people who have like a extremity dedifferentiated liposarcoma. And that study, of course, is also being sponsored and run by SARC. So that will answer this important question of immunotherapy in extremity D-diff lipo, hopefully within the next year or two. And then moving on to the D-diff lipo in the abdomen, that's another kind of challenging case, because I think our practice in most situations is to operate whenever possible if the tumor is technically operable and can be removed. The technical term for that is resectable. With some exceptions, there are cases where we do consider chemotherapy first if the tumor is not quite operable, but if it shrank a bit with chemo, it might become operable. And the other important question is whether chemotherapy in general improves outcome, meaning fewer recurrences, relapses, and better overall survival for people with this diagnosis. And that remains an open question. And there's an ongoing cooperative group study called STRAS-2, which is trying to answer that question by enrolling patients with abdominal D-diff lipo at many cancer centers in North America and Europe. So that is broadly how we tackle well-diff D-diff lipo.
Oh, absolutely. This helps out. So for the vast majority, is we're hearing if it's in the extremity or abdomen, and if it's a well-diff liposarcoma, maybe surgery is usually the first option. If there is a dedifferentiated in the extremity or the abdomen, there are some clinical studies trying to use immunotherapy or chemotherapy, but ultimately, surgery is still an option available for them. And just to kind of keep people knowing, the STRAS study is not just for, I think, D-diff. They do allow other retroperitoneal sarcomas as well. However, one of the cohorts will be the dedifferentiated liposarcoma. That is correct. Mark, a lot of times we do a biopsy, it looks well differentiated. We take it out, and then it says, oh, wait a second. There is a dedifferentiated component despite the biopsy, despite the preoperative imaging. How do you counsel patients after resection on something like that?
Yeah, it's a good question. These tumors are often heterogeneous. So if you look at the scan, there's different areas. It's not uniform throughout the tumor. I think some of these tumors are also very big. They can be, 30, 40, 50 centimeters. So depending on where you get the biopsy, you might see an area that's more well diff or D diff. But when the tumor is completely removed after surgery, the pathologist can carefully look through every section, get a better sense of the geography, as it were, of the tumor. And these tumors evolve, so it seems likely that many start as well diff and then evolve over time to become D diff. So you have components of both in many tumors. In that case, we usually consider the highest grade the most important one. So you think of it as a D diff lipo and treat and follow as appropriate. When I talk about people who have well diff lipo, I'm usually meaning people who have purely well diff lipo with no D differentiated component. But once you have a D diff component, how we think about systemic therapy and surveillance plans and future treatment options and risk of recurrence, that is really the key component, is whether there's any D diff.
No, it sounds like even at expert institutions, despite everything and the right thing being done occasionally, when you get the whole tumor out, you might find some components that might have been there that were just missed on the small little needle biopsy, core biopsy, or on the advanced imaging that you might have had.
Yeah, and I think the other challenging thing is that well diff lipo looks a lot like normal fat, and it's normal to have a lot of retroperitoneal fat in and around the organs and the abdomen. So again, it speaks to the importance of having a surgeon with expertise who knows what to remove and what to leave, because sometimes you can leave behind what you thought was normal fat, but it turns out to be well-differentiated liposarcoma, and the surgery was incomplete. So these are some of the pearls and pitfalls, and why it's, I think, helpful to be seen by an expert team. There's even some nice data from our European colleagues showing that outcomes in general for sarcoma patients are better if they're treated at a high volume specialty center rather than in a small community hospital. So knowing when to refer is really important.
And we continue to highlight this in our practices. You and I practice at major referral centers, but realizing that providing that input and access is key, and that's going to be important for the best outcome of our patients, because that's what's been shown in, as you said, in Europe as well, as some local regional reports as well. Despite the best treatments that we have, surgery and drug therapy, occasionally the tumor will recur. And I know sometimes you get a low-grade liposarcoma that does recur. Sometimes it's a high-grade liposarcoma that dedifferentiated that does recur. And you've done multiple studies in this space, Mark, and maybe you can describe kind of the studies that have been done in this space, as well as kind of your thoughts in your studies that you've used in liposarcoma.
Yeah, sure. So quite right, there's a substantial risk of recurrence, and we follow all patients after surgery with scans every few months, and that interval increases after a couple of years, but we never really say goodbye. There's a risk of recurrence even after 5 or 10 years or longer, so we really follow patients lifelong with rather regular surveillance imaging. And recurrence of the liposarcoma is quite common. It tends to come back anywhere in that retroperitoneal space, which is that big sac that goes from the diaphragm down to the pelvic floor, holding all the abdominal organs. And D diff lipo can also spread to the lungs, which is why we include the CAT scans at the chest. There are many systemic therapies or drug therapies that can be considered if there is a recurrence. But I thought I would focus first on, I think, the question you're asking, which is about the clinical trials, particularly of CDK4 inhibitors, which has been a big interest of mine for years now. So the background is that in the era of DNA sequencing of tumors, we learned pretty quickly that D diff lipo, well diff and D diff lipo, has a particular gene, well, two genes actually, which are overexpressed or amplified in almost all cases of this disease. And those genes are called CDK4, which stands for cyclin-dependent kinase 4, CDK4. And the other gene is called MDM2, which is mouse double minute 2. And those two genes sit next to each other on chromosome 12 and are amplified, meaning that there's too many copies of that gene. So therefore, there's too much of that protein expressed in the cell. And if you have too much CDK4 protein in the cell, it drives the cell to divide and grow faster at a simplistic level. And so it seemed rational to many of us in the field that if you had a drug that could block CDK4, that maybe you could make a difference. Maybe you could slow these tumors down or stop them from growing. That much was clear, but the hard part was how to do it in practice, because for years there were no really effective cyclin-dependent kinase inhibitors that could be given to people. There were non-selective CDK inhibitors. So to say it's CDK4 implies that there's a 1, 2, and 3, right? There's also a 4, 5, 6, 7, 8, 9. And the early drugs blocked all the CDK proteins, and that caused a lot of toxicities that made them quite difficult to administer. And we're not able to hit CDK4 hard enough, I think, to make a difference in liposarcoma. But then everything changed around 2004 when the first CDK4 inhibitor that was selective for CDK4 entered phase 1 clinical trials in humans. And that's the drug that was initially called by a bunch of letters and numbers, but now is known as palbociclib and goes by the brand name Ibrance. So this is the drug that's been tested most extensively in people with well-diff D-diff lipo. Of course, this drug also works in other diseases and has been a big success in breast cancer, where it's now FDA approved. So our group did 2 subsequent phase 2 clinical trials treating almost 100 people with recurrent liposarcoma with palbociclib. And the results showed that, at least in some cases, it seemed to slow down the tumor and improve what's called progression-free survival, which is the amount of time it takes for the tumor to grow. And in rare cases, it also shrank the tumor. So that drug has now been commercially available for people with recurrent liposarcoma based on the National Comprehensive Cancer Network guidelines for the last few years. So that's the first part of the story. And then the sequel to that is that there's a newer and better, at least potentially better, CDK4 inhibitor, which is called abemaciclib, also goes by the brand name Verzenio. This is another drug that's already been FDA approved for breast cancer and is being evaluated now in clinical trials for liposarcoma. And that's really what brings us to this conversation today. We did a phase 2 study of abema at here at Memorial Sloan Kettering, showing that, at least compared to palbo indirectly, it seemed to be somewhat better with improved progression-free survival. And that led us to want to do the definitive phase 3 study, which is the clinical trial that's now underway, sponsored by SARC and open now at 9 cancer centers around the United States.
Mark, you've been the pioneer in using CDK4 inhibitors. You did the 2 major trials in palbo, different dosing, and that became NCCN guideline recommended option for some of our patients. Can you describe, I know you've described this publicly, it's not available at clinicaltrials.gov. What is the actual trial that you are running in SARC 41 and abemaciclib, and how do you approach and how did you design the study? And then why did you decide to come to SARC with this study, since the other 2 studies were done at Memorial?
Yeah, great question. So the other 2 studies were phase 2 studies. So again, when I'm talking to patients, what's the difference between phase 1, 2, and 3? So in phase 1, you're giving a drug to human beings for the first time to make sure it's safe, that there's no toxic effects. And then in phase 2, you're treating larger numbers of people, usually tens to dozens, to get a sense of whether it helps some of the people or delaying the growth of their cancer or shrinking it. And then if you have a signal in phase 2, you really need to move on and do a phase 3 study to provide more compelling evidence that it helps. And in phase 3, you'll usually treat a larger number of people, often 100 or more. And ideally, you're randomizing. So patients who are eligible for the study are enrolled and randomized to your new treatment, in this case, to abemaciclib. And they're randomized to a comparison group who get a different treatment, a standard of care, if there is such a thing, or a placebo. And given that there's not necessarily consensus on what the standard of care is for D-diff lipo, and that a placebo control is reasonable for most of us in the field, this study is actually placebo controlled. So patients are randomized 1-to-1 to receive either abemaciclib or a matching placebo. The patients don't know, the doctors don't know. It's what we call double blinded. And then we follow people with CAT scans every 6 weeks. And if the CAT scans show that the treatment is not working, meaning that the tumor is continuing to increase in size, that's a sign that whatever treatment you're on is not working, and you get unblinded. And if you were getting the placebo, you cross over and you start to take the real abemaciclib tablet. So the advantage of that is that everyone gets a chance to try the new treatment. I think of this as comparing abema now versus abema later. And it will also provide conclusive evidence that abema is or is not a useful treatment for this. And by conclusive, I mean that this is a randomized placebo-controlled phase 3 study that's open at multiple cancer centers, and that level of evidence in medicine is much stronger to persuade people that your new treatment is helpful, as opposed to smaller studies where there's no randomization, where all the patients come from a single institution. So that, in a nutshell, is SARC 41.
Mark, I've started to use your lingo now versus later in trying to convince people to, as you might imagine, there's a little hesitancy at some point going on. I'm not sure I'm getting a real drug or placebo, but as you said, if they're healthy enough and they progress and they were on the placebo, they will get the real drug. And I think that's a value, and I think you built in a lot of safety measures to make sure that you have enough appropriate scans to catch somebody who needs to be converted over and unblinded. So we look forward to these results, and I know that patients like to go on a trial. So it's great to have a national trial in multiple centers across the United States through SARC. However, you did comment that D-difference liposarcoma had two targets, CDK4 as well as MDM2. What is your thoughts on where the field is in targeting MDM2 that's been publicly announced, or where do you think we should go in that field?
Yeah, MDM2 drugs are earlier along in development than CDK4, with, as far as I know, none commercially available or FDA approved. And they have been tested in phase 1 studies in D-diff lipo, and we have seen publications suggesting that some patients may get benefit. But as with the CK4 story, you need to do a larger phase 3 study to clinch the deal. And recently, a large phase 3 study was done, which compared an MDM2 inhibitor to another chemotherapy drug often used for recurrent liposarcoma called trabectedin. And the study results have been reported as negative, meaning that the MDM2 inhibitor was not shown to be better than the trabectedin, but the details have not yet been unveiled. So I think we're all looking forward to looking at that data in more detail. I think it's always discouraging to see a negative phase 3 when you consider the investment in resources, time, effort, plus all the patients who went on that study hoping to find a better treatment for D-diff lipo. However, I think we still need to look at the data in more detail and parse it through. One of the challenges in designing a phase 3 study with a control arm that's a chemotherapy is, well, if your new treatment is just as good as your old treatment, then your study is going to be negative, meaning that it's not better than your old treatment. But perhaps both treatments are useful. And so we need to find a way to get more useful drugs in the toolkit to offer to patients with this disease.
Well, Mark, just like you said, the evolution of palbociclib, abemaciclib, there are other cyclibs out there, and maybe abemaciclib is better than palbo. We won't know. And just maybe, like you said, the target is the right target, MDM2, maybe the trial design, as we learn more and more about what was actually done, or that targeted way we gave it. It's still a reasonable thing to pursue. We just need more time on this. And as a community, I still think people are still interested in MDM2. It's just that, the sales, the wind in our sails kind of got shut down a little bit. But I do think we need time to look at that data once it does become available. And I don't know what your thoughts of, is this target still dead in the water, or as I'm kind of hoping, no, we need to give it a little bit more time before saying no.
Yeah, I tend to agree with that. It's probably valid and needs more time. It's just tricky because the CDK4 inhibitors were already approved for other cancers like breast cancer. And so they could be sort of moved laterally into different diseases like D-diff lipo. And I think the problem with MDM2 inhibitors is they're not officially registered for any disease yet. So there's not even a potential for, off-label use based on NCCN or any other favorable phase 1 data. So figuring out a registration strategy for an MDM2 inhibitor is still a big challenge for the field.
So that just reminds all of us that there's still work to be done, and that advancement of clinical trials to solve and answer questions are still going to be important, whether it's through SARC, cooperative groups, or other mechanisms. I do think is going to be valid. Mark, we've gone through a lot in the last while here, talking about, sarcomas, liposarcomas, well-diff, D-diff, the differences between pleomorphic and myxoid lipo, options regarding systemic therapy using CDK4 inhibitors in your studies that you have done. You've kind of shared that, at some level, you probably want some expertise to look at this case because there are nuances that you've picked up along the way. You and I didn't grow up with all these nuances. We've learned them. We've, gone to meetings to understand that. However, people that are listening to this podcast might want to gain some pearls of wisdom from you, Mark. And I don't know what pearls of wisdom you'd like to share to the oncology team that potentially be listening, or a family member that's listening, about the management of liposarcoma that you are willing to share.
Well, I think the first thing I would suggest to a general practice oncologist is, when in doubt, refer. And we're very happy to work with colleagues and doctors all over the country and the world to help care for their patients, which doesn't necessarily mean that the sarcoma specialist needs to take over all their care, but seeing them once or twice to help guide the best treatment options that could be administered close to home is something that we happily do on a weekly basis. And I think certainly referring for pathology confirmation to make sure you have the right sarcoma subtype and the right treatment plan in place is critical. And I think the other thing for patients, their doctors and their families, is to try to remain optimistic. I've been at MSK now for 17 years. A lot has changed. Treatments for D-diff lipo available now that we didn't have when I started include not only Palbo and the Abema trial that we talked about, but even chemotherapies like eribulin or trabectedin, or immunotherapies, which are now increasingly commercially available for D-diff lipo, like Pembro and Ipi-Nivo. None of this stuff was around even 10 years ago. So we are making progress and new treatments are coming along. And I think we're cautiously optimistic that we'll find better options for patients, understanding that it's still a long road ahead. And as sometimes it feels like 2 steps forward and 1 step back, but we try to stay optimistic.
I like your comments of staying optimistic. And I think the part that I think most patients, and I think referring physicians know, I think most referral centers are busy enough that if standard of care can be done locally after expert opinion, you're going to get your patient back, or a family member, you're going to have your patient, your loved one, get care locally with some input from an expert opinion saying, yep, the oncology team has looked at it and things are moving in the right direction. If things change and you want to come back, we'll be happy to re-engage as appropriate, because there will be hopefully another clinical trial and or real advice to say those changes we see, yep, represent recurrent disease. No, that does not represent whatever. And you might have options that we might not have in the general community oncology practice. So I like your idea, refer often to get input, but knowing that a lot of the care can and is delivered locally, and to remain optimistic. We only touched on CDK4 and MDM2, but as Dr. Dickson said, there's a huge amount of other systemic drug therapies that are available in this space, and we're just touching a few things here. So Mark, you did kind of say that you have words of encouragement for your patients. You're a big group at Memorial Sloan Kettering. You're not the only person that sees liposarcoma, or are you the only person that?
No, not at all. We have about a dozen faculty right now in medical oncology who are full-time treating sarcoma. So it's a great group to work with, and really privileged to have so many colleagues to bounce ideas around and to share cases with.
Yeah. So I think one of the advantages, I think, Mark, is you're highlighting is, even if there are cases that you're very comfortable with, you have the resources of multiple other medical oncology colleagues that can weigh in to give you guidance as well. And I think that's the value of getting to a referral center. It's not just N of 1, it's an N of 10 to 12. You might be up to more than 12 people. How many do you have there now, Mark?
That's right. It's a dozen medical oncologists, pediatric oncologists, many pathologists with sarcoma expertise, radiologists. So the tumor board really have a big brain trust, and we review every week all the new patients that we see, which is over 1,000 a year. So I think that it is reassuring to patients to come to a place where your team can say, you have a very rare diagnosis, but we've seen 4 of them this afternoon already, that kind of thing. So,
no, we do appreciate that. And for those that can't get to Memorial Sloan Kettering, on our SARC website, we do have other sarcoma centers across the United States that have key contacts as well that we feel as though they have enough expertise as well above and beyond Memorial Sloan Kettering. Mark, thank you for sharing your knowledge and expertise on liposarcoma to us and our group listening here today or in the future. Do you have any final thoughts or comments?
I'll tell you a brief anecdote. I read a science paper recently that described a fossil of a dinosaur that was 70 million years old. And in that fossil, they found a sarcoma in the bone. And that made me realize that this problem of cancers developing in animals, humans and dinosaurs, is a deep, deep problem of multicellular life that has been going on for a long time. And we have to think really hard about how to get better outcomes with something that has been with us for a long time, and unfortunately probably still will be with us for a long time to come. But I still remain optimistic that there'll be ways to find better treatments, and maybe really within the next generation, earlier detection, so that we nip these in the bud when they're small and easily curable. So that's my hope for the next 25 years or so.
Well, that's outstanding. And Mark, the dinosaurs didn't have a Dr. Mark Dickson working on this as well. So hopefully we don't have to wait another 70 million years to come up with something. So maybe in the next short while here. So thank you again. For those that are listening, please share this SARC Talk with those that are interested in sarcoma. Please leave comments and suggestions about our SARC Talk podcast, and we'll address that at our next SARC Talk. Looking forward to a great summer, and July is Sarcoma Month, so hopefully everybody will have time to reflect and cherish Sarcoma Month in July.
Thank you for listening. Be sure to subscribe so you never miss a SARC Talk. To find out more about SARC, please visit our website at sarctrials.org. To suggest a topic or for questions, please email us at sarctalk@sarctrials.org. The SARC Talk series is made possible due to funding from Adi Biosciences. Together, we can find a cure for all forms of sarcoma.